Good afternoon. My name is Jack Wetzels. I'm a nephrologist at the Radboud University Nijmegen in the Netherlands. And it is a pleasure to welcome you all to this webinar. And it's a pleasure to introduce Simone Baldovino, who is Assistant Professor of Clinical Pathology at the University of Turin. Simone was trained as biochemist and clinical pathologist and also as MD, and has a long-standing interest in rare kidney diseases and especially immune-mediated diseases and also amyloidosis. And this amyloidosis will be the topic of his lecture today. And it is a pleasure to introduce Simone and well, Simone, start your presentation.
Good afternoon. Thank you, Jack. Thank you all to be here this afternoon, attending this webinar about a pathology followed typically by adult nephrologists, a pathology that we share with many other specialists, such as hematologists, immunologists, cardiologists, and that is treated by at least 2 other European reference networks, such as RITA and ERKNet. So this is today's agenda. First of all, I want to introduce amyloidosis and explain something more about the pathogenesis of this very peculiar disease. Amyloidosis are pathologies characterized by the deposition of fibrils made of peptides or proteins that typically accumulate in the extracellular environment. Generally, amyloidosis is a systemic disease, but different types of proteins hit specific organs. And so we can observe different patterns that are quite typical for the different forms of amyloidosis. When we look at the amyloid fibrils under the electron microscope, they look like pine needles arranged irregularly on the ground. Typically, amyloid fibrils are stained with Congo red and azo dye, used only for the characteristic of binding amyloid fibrils. When we look at the amyloid deposits stained with Congo red using polarizing microscope, we observe a typical apple green birefringence. When we look it under the fluorescence microscope, we see a red fluorescence that is quite peculiar, like you can see in this file or in this glomerular. The dyeing characteristics and the typical birefringence and the fluorescence of Congo red are due to the conformation of the amyloid fibers, which allow the dye to be regularly interspersed within them. And now we can see better how these fibrils are formed. Well, first of all, the fibers are not formed by only one type of protein. In fact, typically the deposits include also glycosaminoglycans that facilitate the deposition of amyloid fibrils. And it's interesting that the different composition of glycosaminoglycans in the different tissues can partially explain why different amyloid precursors have the tendency to deposit in different organs and tissues. Moreover, in every amyloid deposits is present a serum protein called the serum amyloid P protein, or SAP. This is a protein of the class of pentraxins that co-deposits with all amyloid fibrils. And these characteristics and the presence of SAP in every amyloid deposits has been used to produce a scintigraphic marker. The colleagues from the London group developed a tracker using SAP marked with radioactive iodine, and used it to visualize amyloid deposits in different organs. Unfortunately, to date, this method is not routinely available outside the United Kingdom. The polypeptides that form the fibrils are characterized by the presence of a higher number of beta sheets than that we observe in the native protein or in protein not associated with amyloidosis. And the beta sheet sequences make these polypeptides more sticky. So they join together, first forming oligomers, and it's interesting that also oligomers are considered to be cytotoxic, and then they form the fibrils. It's a little bit like when we play with Lego bricks. We can build very complex and regular structures starting from identical bricks. And this is what happens in amyloidosis. These polypeptides can form fibrils because they are much concentrated in blood, because they are produced in an abnormal number, as it happens in amyloidosis associated with light chains of immunoglobulin, or in amyloidosis associated with the serum amyloid A protein, or because they are mutated and they are more sticky, as happens, for example, in transthyretin-related amyloidosis. In the last slide, I introduced you some of the protein involved in amyloidosis, such as immunoglobulins, light chains, amyloid A, or transthyretin. But to date, we know more than 30 different precursors. The last classification of amyloidosis made in 2018 included 36 different precursors in human amyloidosis. 17 of these are associated with a systemic form of amyloidosis. As you can see in this picture, the form associated to light chain of immunoglobulin, the form associated with serum amyloid A protein, and the form associated with transthyretins are the most frequent form of amyloidosis. And as you can see, the heart is the organ that is most frequently involved in amyloidosis, naturally followed by the kidney. This diagram illustrates in an easy way how to classify all the forms of amyloidosis. First of all, we must distinguish localized form from systemic forms. Then we must characterize the type of protein involved. IL amyloidosis is also called primary amyloidosis. while the form associated with serum amyloid high is called secondary amyloidosis because historically this form was associated with infectious and autoimmune diseases. Now, the leading cause of amyloid A, this form of amyloidosis are autoinflammatory diseases that are genetically determined form of inflammation. And then there are the so-called genetically determined form of amyloidosis. Which are the organs involved in systemic amyloidosis? Well, if we talk about the genetic forms, they hit different organs according to the type of mutated protein. The kidney is typically involved in ApoA1 and ApoA2 forms, and also in lysozyme and in gelsolin form. But also transthyretin can involve the kidney, even if it's considered a typical form of heart and of peripheral nervous system. On the other hand, the AA form typically involves the kidney. And finally, the AL form involves every organs and apparatus, but the leading cause of death in patients affected by this form of amyloidosis is the involvement of the heart, followed by the kidney, as we will see after during the presentation. When you can find an amyloidosis, first of all, you can have an occasional finding. The first patients affected by amyloidosis that I followed in 2004 was admitted to our hospital because of a spontaneous rupture of the spleen due to a massive spleen and liver infiltration by light chain amyloidosis. On the other hand, you can reach a diagnosis following a targeted suspect. Here you can see which are the symptoms and the signs that can suggest the presence of a systemic amyloidosis. I want to underline the presence of macrogloxia, the presence of bilateral carpal tunnel syndrome, the peripheral neuropathy, often associated with dysautonomia, and dysautonomia can also provoke orthostatic hypotension. Regarding the kidney, the typical sign of renal amyloidosis is the presence of massive proteinuria, often in the nephrotic range. However, some types of amyloidosis, for example, the one associated with apolipoprotein 1 and 4 mutation, are associated with medullary involvement, with worsening of the renal function, not associated with proteinuria. Involvement of the heart is associated with diastolic heart failure with a restrictive pattern, and involve the increasing of marker of myocardial necrosis such as troponin, and of heart failure such as NT-proBNP and BNP. Also typical of IL amyloidosis is the presence of low voltage in the peripheral derivation of the EKG. Then higher the elevation of cardiac marker is also associated with a worse prognosis in AL amyloidosis. The diagnosis of amyloidosis require to prove the presence of amyloid in the tissue, and so a biopsy is always mandatory. The easier form of biopsy is the so-called periumbilical fat aspiration, but even better, you can perform a periumbilical fat punch biopsy that allow to tackle more fat tissue and moreover allow you to take also some dermal connective tissue that contain many blood vessels in which wall you can observe the presence of amyloid deposits. Unfortunately, periumbilical fat biopsy has a quite good specificity, but a fair sensitivity. Especially when you suspect the presence of a genetically determined form of amyloidosis. And in this case, you could perform a biopsy of other soft tissues, such as the rectal submucosa, like you can see in this picture, or minor salivary gland. When there is a scene of renal involvement, kidney biopsy is a very good alternative because it can help you in the diagnosis and has a higher sensitivity than the biopsy of fat tissue, and it's also useful to establish prognosis because higher is the number of nephron involved by amyloid deposits, worse is the prognosis. It's now time for the first question. The diagnosis of renal amyloidosis is based only on clinical findings, laboratory findings, instrumental findings, histological findings, all the evaluations reported above.
Okay, Simone, you're going to answer the question.
Okay, I don't see the answer.
Okay, so I can tell you. So the 33% of the audience filled in D, the histological findings.
Okay.
76% filled in all the evaluations reported above.
Okay. Perfect. Okay. The correct answer is D, but also E can be correct because, as I said, histological findings are mandatory, but also the other evaluations are important to reach a correct diagnosis and also to suspect the presence of amyloidosis. So if you answered E, you are not so incorrect. I think that I can go on now. Okay. After proving the presence of amyloid deposits, is mandatory to typing these deposits because different type of amyloidosis require different treatments. And as you can see from this whole work from the London group, that is still up to date, unfortunately it's still up to date, the misdiagnosis of the type of amyloidosis is not infrequent. And it's also important, another note that emerges from this study, as you can see, the presence of a monoclonal gammopathy in a patient with a biopsy-proven amyloidosis is not automatically a proof of an AL amyloidosis. The typing of amyloidosis can be performed using immunofluorescence. Here you can see renal biopsy showing AA amyloidosis, and here you can see a biopsy showing amyloidosis due to the presence of lambda light chains from immunoglobulins. However, often the antibodies used for this technique are not very specific, and there are frequent overlapping in their reactivity. For example, antibodies for AA often cross-react with transthyretin. Electron microscopy associated with immunogold staining is more specific, but it's time-consuming, and it's not so widely available in every pathological anatomy center. And moreover, it requires the presence of frozen specimens. Quite recently, the group studying renal amyloidosis from Heidelberg introduced and made available to all the world some antibodies that are very specific and that can be used to perform immunohistochemical analysis also on specimen fixed with formalin. And this type of antibodies permits to readily type the most frequent type of amyloid fibrils. By now, the analytic gold standard for amyloid typing is the proteomic approach. This technique, here you can see how is performed the so-called target proteomic approach, is widely used in some centers such as the Mayo Clinic, but it's not commonly and currently used in the majority of centers in Europe, because it's quite time-consuming and also requires the availability of a mass spectrometer. However, it permits to identify the proteins involved in amyloid deposits with the highest specificity, and maybe in the future it will be used for all the diagnosis of amyloidosis. Genetic approaches are important when we suspect a familiar form or when we observe the presence in the amyloid deposits of specific proteins such as transthyretin, apolipoprotein A, 1 or A2, and so on. It is also important when we observe the deposition of amyloid A in our amyloid deposits, and we have no underlying evident cause of inflammation, such as chronic infection or an autoimmune disease. In this case, we can suspect the presence of autoinflammatory diseases such as Mediterranean fever or TNF receptor-associated syndrome, or the presence of the so-called cryopyrinopathies such as Muckle-Wells syndrome. These type of autoinflammatory disease are associated with different frequencies with the formation of amyloid deposits. It's now time for the second question. So the gold standard for the typing of amyloid deposits is Congo red birefringence, immunofluorescence with commercial antibodies, immunogold with commercial antibodies, immunohistochemistry with homemade antibodies, mass spectrometry.
Yes, the audience, please fill in the answer you think is the correct one and submit the answer. Few seconds and then we will close the poll. Okay, Simone, can you see the answer?
Yes, I can see. Also, it's now I see that the answer is differentiated between immunofluorescence with commercial antibodies and mass spectrometry. And someone also wrote congruent birefringence. So the first answer is not correct because it's the gold standard for the diagnosis of amyloidosis, not for the typing of which protein is causing the amyloidosis. The second answer could be correct, but as I told you before, there are many cross reactions between the different antibodies. Immunohistochemistry with homemade antibodies, as I said, is now widely used after the Heidelberg group produced some quite specific antibodies. But the gold standard that to which we have to confront is a mass spectrometry. I don't want to tell you that you have to perform mass spectrometry on all of your patients, but if you have some contrasting result from the other techniques, mass spectrometry is the technique that had the higher specificity for typing the amyloidosis deposits. It's now time to tell something more about the kidney. And as I told you before, the kidney is often a target for amyloid deposits and is the second organ after the heart to be associated with a worse prognosis, especially in patients affected by IL amyloidosis. Different types of amyloidosis involve different kidney structures. However, the glomeruli and the vessels are the most involved ones. As you can see in this recent work from our group, in light chain amyloidosis, that, as I told you, is the most common form of renal amyloidosis, glomeruli and vessels are always involved, and even if more than 50% of cases present also the involvement of interstitium. And it's also important to say that the involvement of nephrons and the number of nephrons that are involved correlated with the prognosis. So I would like to underline that when it's possible, a renal biopsy is quite important when there is a renal involvement. And kidney biopsy is also important for the typing of the amyloid deposits if this was not possible from other biopsy specimens. And the most common type of renal amyloidosis are light chain followed by AA amyloidosis. The genetically determined form are not so frequent, but can have a higher frequency within some population. For example, in Italy, apolipoprotein-related forms are more common in Lombardy, and transthyretin forms are more common in Sicily and in Piedmont. A quite peculiar form is the one related to the leukocyte cells derived chemotaxin 2 that was firstly described by Benson and colleagues in 2008. And this form is quite common in American patients of Hispanic ascendance. But it doesn't seem so frequent in Europe. And it's now time for the last two questions. The first is when suspecting systemic amyloidosis, kidney biopsy is contraindicated because there is higher risk of bleeding, contraindicated because there is higher risk of thrombosis, contraindicated because the kidney biopsy is not sensitive, useful to provide information when there are signs of kidney involvement, and mandatory in any case.
Thank you. May I ask the audience to answer the question and try to submit the answer? Okay, we will allow a few seconds and then we will close the poll. Okay, let's close.
Okay. Okay, perfect. The vast majority of the attending people put the correct answer, so it provides quite important information. It's not mandatory in any case. It's important to perform biopsy whenever it's possible, but it's not mandatory in any case. I would like just to answer to the people that answered A, so contraindicated because there is higher risk of bleeding. And this was a contraindication in the past about when I started to follow amyloid patients. It was considered a contraindication because patients affected by AL amyloidosis can have a worse coagulation due to the consuming of factor 10 of coagulation by the circulating amyloid oligomers. However, when we perform a biopsy with the techniques that are now available and we prepare the patients correctly before the biopsy, there is no higher risk of bleeding. And the last question, the most common form of renal amyloidosis is AL amyloidosis, AA amyloidosis, amyloidosis related to transthyretin, amyloidosis related to lysozyme, and amyloidosis related to gelsoline.
Please provide the answer. Okay, we will wait for a few seconds and then we will close the poll.
Okay, perfect. So about 2/3 of the audience answered the correct answer. So AL amyloidosis, and 1/3 answered AA amyloidosis. This was a form of amyloidosis that was quite frequent in the past, and maybe it's still frequent in some other countries and continents where some chronic infectious diseases such as malaria or tuberculosis are still diffused. In Europe, it's not so frequent, and also the frequency is lower now because another leading cause of AA amyloidosis that was correlated to untreated rheumatoid arthritis is now virtually not present because of the very efficacious therapies that are now present. So now I would like just to suggest you some principle of treatment. I don't want to tell you everything about treatment because it requires quite a long time. And just to summary, the therapies for amyloidosis aims to three different targets. First, we can reduce the concentration of the precursor protein in the blood, and this can be obtained in different ways according to the site of production. In the case of AL amyloidosis, we must destroy the clone that produces them. In the case of amyloidosis related to serum amyloid A, we must reduce the systemic inflammation, and in the case of transthyretin amyloidosis, we must reduce the production of the mutated protein by the liver using the liver transplantation or inhibiting the transcription of transthyretin using inhibitory RNA. Second, we can interfere with fibril formation using, for example, glycosaminoglycan mimetics or little molecules that stabilize the precursor protein, increasing their solubility in the blood. Third, we can try to remove the protein already present in the deposits. And one of the most interesting molecules in this group is the epigallocatechin gallate, that is a component of green tea that seems to be quite promising in the removal of amyloid deposits due to light chain and to transthyretin. The treatment of the patients require an accurate evaluation of their performance before initiating any therapy. For example, in the case of patients affected by light chain amyloidosis, we can use a classification that divides the patients in three different groups, the so-called fit, intermediate, and frail group, according to their age and also to their clinical state and to some laboratory tests such as cardiac troponins and NT-proBNP. As you can see, this group have different prognosis, but can also be subjected to different treatment regimens. A recent evaluation of some of our patients, most of them with renal biopsy-proven involvement, showed that in the presence of renal involvement, the prognosis is worse. You can see that about 1/4 of patients without renal involvement died during the follow-up, instead, more than half of the patients with renal involvement died during the follow-up. Moreover, in the patients with renal involvement, worse GFR correlated with higher risk of dying. And this data suggests that patients with renal, as well in those of clinical treatment, we need to use a treatment that rapidly reduces the concentration of circulating light chains, and we need to rapidly reach the so-called hematological response, even in patients that are not eligible to the gold standard that is the autologous stem cells transplantation. And by now, there are many therapies for the treatment of this type of amyloidosis. These therapies are translated from the treatment of myeloma, and we recently tried to treat 4 of our patients with renal amyloidosis using daratumumab, a monoclonal antibody that target the CD38, a protein that is typical of plasma cells. And the results are quite promising, and we reached very rapidly complete hematological response, and the proteinuria was reduced steadily in 3 out of 4 of these patients. So, what are the most important take-home message from the lesson? First of all, renal biopsy is not mandatory, but I think that it must be performed whenever possible if there is any signs of kidney involvement. Instead, it is mandatory to type the amyloid deposits in any histological specimen that you can obtain, because the type of amyloid deposits guide the therapy. Third, I would like to underline that GAS, the monoclonal gammopathies of undetermined significance, are not so benign as you can think, and so I think that it's important a periodic follow-up, for example, each year, controlling in these patients the presence of proteinuria and the level of NT-proBNP to promptly diagnose an overlapping amyloidosis. And finally, IL amyloidosis is a form that requires prompt treatment to stop the deposition of amyloid fibers in the heart and in the kidney, and you have to try to reach a complete hematological response if you want to obtain a good organ response. Thank you for your attention, and now I have to present the next seminars of this series. The first of all will be next Tuesday, and will be about nephronoptosis. On 11th of June, Roxana Schroff will talk about the recent consensus document on vascular access in children requiring maintenance hemodialysis. And finally, on the 23rd of June, Albertine and von Hard will talk about genetic causes of end-stage renal disease in all those patients. And I think that he would talk also about amyloidosis. Thank you.
Okay. Thank you, Simone, for this nice presentation where you demonstrate that the diagnosis of amyloidosis really needs, let's say, a lot of expertise. I ask the audience that they can ask questions by putting a question of asking the questions in the control panel, and I will then give the answer to you. And while waiting for questions, maybe I can ask one myself to start with, and that's the question that, let's say, in many patients, especially elderly, you can find a monoclonal gammopathy, which we often call monoclonal gammopathy of unknown significance. And then if you have a patient with proteinuria and you would perform a biopsy, how often do you think you would need additional techniques to make sure that you have AL amyloidosis? So in your experience, how often do you think that the staining of the kidney biopsy for the kappa and lambda change is insufficient to make sure that the diagnosis is AL amyloidosis?
Well, I don't have a precise percentages of patients with other type of amyloidosis. But I would like just to use what we can learn from another type of amyloidosis, that is the transthyretin form of amyloidosis. It's now a growing cause of heart failure also in elderly patients, because it's associated with the so-called senile cardiac amyloidosis. In these patients, we must mandatory perform also genetic analysis, because some patients can have a form due to mutation of transthyretin, even if we can think that they are old and they can have a mutation due to the presence of wild-type transthyretin. So I think that when we perform a kidney or a biopsy of the fat tissue, we must ever perform atypization. We can use antibodies. We don't have to use the mass spectrometry, but I think that the typization is always mandatory, because as you can see from the results from the London group that I presented, many patients that we suspect to be affected by AL amyloidosis have other forms.
Okay. I have a question from Dr. Sprangers from Leuven, and the question is: do you have experience with kidney transplantation in patients with AL amyloidosis, and what do you require for hematological remission before embarking on a kidney transplantation in these patients?
Okay, perfect. So we have some patients with AL amyloidosis that were transplanted after they reached a complete hematological response. It's important to reach a complete hematological response before the transplantation, and I think that these patients had a quite good prognosis after kidney transplantation.
And in your center, do you do the autologous stem cell transplant before the kidney transplantation, or?
No,
Yes, in all cases.
it depends if the patients are eligible to the autologous stem cell transplantation. We have also some patients that were not eligible to this form of treatment because they had a kidney involvement, an important kidney involvement, and this was a contraindication from the hematological point of view. They made other treatment regimens. They reached a complete hematological response. They were transplanted. There was also one patient that reached a transplantation from a living donor, and they had a very good outcome.
Okay. Then the next question from Anna Sukuma, and the question is this an area where stem cell research can help?
No, maybe can help in the genetic form of amyloidosis that cannot still be treated with treatment like the inhibitory RNA. I think that maybe we can try to use a stem cell to make the right protein in the organ that produce the mutated protein. But it's by my knowledge, now there aren't many studies in this field.
Okay. Then another question: do you have any experience with apheresis techniques to remove amyloid? And the poser of the question, Victor Alfonso Lopez, suggests that there are some data that in some dementias where you have amyloid deposits, you can remove the deposits. But
yes, the study that are about another type of amyloid protein that is the beta amyloid that is present in many dementia, such as Parkinson disease or such as Alzheimer's disease. In this case, the precursor is a very little protein. It's between a polypeptide and a protein, and so it can be removed easily by using the apheresis. Apheresis can be also an option in the patients affected by AL amyloidosis with very high concentration of monoclonal protein, but it's not the typical case of amyloidosis. We can observe a very high concentration of monoclonal proteins more often in other type of renal disease, such as cast nephropathy. In amyloidosis, the concentration is often quite low, even undetectable, because the problem is not the concentration of the protein, but the fact that they are quite sticky for the target organs. We have a quite interesting experience with a patient that was treated with that was affected by AL amyloidosis, and also with another patient affected by transthyretin amyloidosis, in which we used peritoneal dialysis to remove the precursor protein, and we could observe a lowering of the concentration of transthyretin in one case and of light chain in the other after each treatment with peritoneal dialysis, because you can use peritoneum like a filter.
Yes, but it's not let's say standard techniques which we would use regularly to treat patients with amyloidosis, I think.
No, it's not standard. Yes.
Yeah. Okay. I think we are out of questions and also out of time. It's 5 o'clock. So I thank you, Simone, for this presentation. I thank the audience for listening, and welcome you to the next webinars of ERKNet. Thank you all and have a nice afternoon.
Thank
Bye-bye.
you. Bye. Bye.